Managing the health of a massive population requires systems that can rapidly scale and identify anomalies across vast geographies. Reducing the maternal mortality rate relies on the early detection of high-risk pregnancies during the second and third trimesters. This creates a significant logistical hurdle, identifying a small percentage of patients with dangerous complications among millions of routine pregnancies. Standard, passive clinic hours often fail to capture these cases in time. The scale of the population demands a coordinated intervention to evaluate as many women as possible simultaneously. Reducing MMR across a massive population turns a clinical challenge into a problem of systems engineering and resource management. India's solution is the Pradhan Mantri Surakshit Matritwa Abhiyan, or PMSMA. It is a fixed-day strategy occurring on the 9th of every month. On this day, the entire public health infrastructure mobilizes, while private medical volunteers are integrated directly into government clinics. Absorbing a massive patient surge on a single day creates an immense strain on local clinics. To understand how the system manages this volume, we have to look at the mathematical framework that governs the district-level planning. The 9th of the month functions as a high-density triage operation designed to process patients through a synchronized diagnostic loop. Operational planning begins at the district committee level. Before any patients arrive, officials use load estimation formulas to predict volume. This formula establishes a baseline for the monthly surge, using the district's total population and birth rate. For instance, in Guntur district, calculating these metrics alongside historical coverage rates predicts a monthly surge of over 5,700 patients. That number dictates the exact human resource ratios. For every 100 patients, the facility requires 2 medical officers, 2 staff nurses, 2 lab technicians, and up to 4 auxiliary nurses. The clinical success of the day depends on the presence of specialized obstetricists to diagnose high-risk factors accurately. These calculations typically show that the public sector alone lacks the specialized doctors needed to handle the mathematical surge. To meet this deficit, the framework must systematically pull in talent from the private medical sector. A 3-stage operational funnel integrates private doctors into the public workflow. First, awareness campaigns drive practitioners to a registration portal. Second, district officers map these registered volunteers to public clinics facing the greatest staff shortages. Logistical support, such as covering travel expenses, is provided to ensure the volunteer actually reaches the designated rural or sub-district facility. The final challenge is retaining these volunteers without offering direct financial compensation. The sustain phase utilizes social capital and public recognition in place of a salary. Doctors are awarded bronze, silver, or gold medals based on their service and elevated to a virtual Hall of Fame. This creates a predictable flow of specialized labor to meet the surge on the 9th of every month. By treating private goodwill as a managed utility, the framework solves the primary human resource constraint of the campaign. Inside the facility, the macro-level planning transitions into micro-level execution as the scheduled patients begin arriving for their crucial examinations. A strict clinical workflow is used to prevent the clinic from becoming a bottleneck. Auxiliary nurses handle the initial intake, checking vitals and issuing mother and child protection cards. The patient then moves immediately to the lab. The framework mandates collecting all blood and urine samples beforehand, ensuring the physician has the necessary data the moment the physical examination begins. All lab tests must be processed and handed back on the same day. Patients aren't sent home. Once the reports and ultrasound are ready, they proceed directly to the obstetrician. The doctor can now perform a high-efficiency examination, fully informed by same-day diagnostic data. This specific order allows the clinic to process hundreds of patients while maintaining the diagnostic data required for each evaluation. Every piece of this logistical system, from the population math to the same-day lab work, exists to produce one singular output. At the end of the exam, the doctor categorizes the patient based on the immediate findings. If a complication is detected, a red sticker or stamp is applied to the patient's protection card. This visual marker isolates high-risk patients on the thousands of healthy pregnancies processed during the surge. This sticker activates the longitudinal tracking protocols that follow the patient for the remainder of her pregnancy. The red sticker triggers an SMS alert through the mother and child tracking system. This adds the patient to a community health workers line list for village-level tracking and links her to a first referral unit equipped for obstetric emergencies. The patient is provided with emergency contact numbers and a clear pathway to specialized care before she reaches her due date. The 9th of the month serves as the entry point for a tracking loop, designed to connect the most vulnerable patients to the emergency care they will eventually need.